All right, we'll wait just a few more minutes. It's just now 9:30, but we'll wait another minute or so and see if everybody gets logged on. All right, so looks like majority of people are here. A few that aren't, you can log on when they log on. So I'm going to unshare this for a minute, which may or may not be a good idea since it takes. Right. I guess I'm not. All right. So does anybody have any questions about, I want to unshare this real quick so I can see you. So difficult. Anyway, does anybody have any questions about the cultural assignment? I haven't gotten any emails or.
I have a question actually. Is this like from just a first person like perspective, or is this like an APA like research paper that like we need to like cite?
No, I mean, no, I don't want it to be a paper. What you're going to turn in is actually your PowerPoint. So the whole thing is the presentation, if that makes sense. So go ahead.
Do we have to do a voice thread over it, or we just turn in the PowerPoint like?
Well, no. If you, let me see, how can I explain this? It's so different doing everything online. What you need to turn in is the PowerPoint. And if you don't like PowerPoint, if you'd rather do something different, I mean, I've had people in class that did other things, chose not to do a PowerPoint, but we were live, so they did a presentation of some sort. I think in this case, with everything being online, that it will probably need to be something like a PowerPoint. Then the second part of it is it will be something that you will download, and there'll be 5 or 6 other people that will watch it. So that needs to be more than just a PowerPoint. That needs to be you presenting. So a voice over the PowerPoint or something like that. Does that make sense? Does that help?
Yeah. So like in other classes when we do slides, like it's with a voice thread. So you're saying we can use whatever media we want as long as
voice thread is fine. I don't know what everybody's comfort level is with voice thread. Is that something that with this all going on that you've used a lot more?
I mean, I've only used it a couple of times, but I just wouldn't know how else to record the voice over the slides.
Yeah, there is a way to do the audio over the PowerPoint, and I've got the instructions on how to do that. I think, and then of course VoiceThread is a good option. I know I tried to use VoiceThread in a class last year, and people had never used it before, and it was, it's not hard to use, but again, it's something that if you've never, last spring we were all running around with our hair on fire trying to figure things out. So I understand that this is a little different. This semester we know a little bit more. So that is absolutely fine. I will find and send or put in Blackboard the instructions on how to make a PowerPoint and make the audio with it. And I'll also download the instructions on how to use VoiceThread so that you have those options.
Okay, thank you.
Okay. I don't care what you use. I mean, but it needs to be something that we could, that the 4 or 5 people that are going to kind of be in your watch group can access. So, and again, for those who haven't used VoiceThread, it's a part of Blackboard, and it's really pretty cool. It's good to use, but I recognize not everybody has used it. So, when we do this in class, and that's the other thing. If you want to do a video, that's another option, is that you can, because in class I've had people bring in, not do a PowerPoint, but literally do a presentation and like have slides, have props, whatever they want it to bring in, depending on the culture. People make baked goods, so I kind of miss those days, but so it can be whatever, whatever the presentation you want it to be. So if you want to do something like that, where it's just if you're feeling like I want to make a video, I want to talk, I want to show props, and I want my grandfather who's a whatever of this nationality is going to talk, then do that. But it just needs to be something that we can download and access. So when I say it's due, the assignment is due, that's just when I want whatever that thing is available. Sound good?
Okay, so
There need to
it's
be a
a PowerPoint by itself and then some sort of PowerPoint with a video, like 2 separate uploads?
No, it can be the same upload.
Okay.
Yeah. I'm not trying to make it hard. I'm trying to make, it. I don't think adding audio to the PowerPoint's all that difficult, to be honest. We just have to, have to know how to do it. So, because I know we did it a lot in the spring. I have graduate students in their practicums and undergrad in their practicums. That's what they had to turn in. What they do, a poster presentation. I don't know if any of you all are in that class. It's like the seminar and the for your practicum and internship in undergrad, and it's always been a big poster presentation where they do this. It's not really research, but they do this sort of project and then they present it on a poster. Well, of course, last spring they couldn't do it, so they all had to do PowerPoints, and so they all had, we had to figure out how to do the PowerPoints with audio, and so it can be done. It's not hard. We just, we just haven't done it that much. Yes. Jasmine.
Sorry. You might have already said this. So are we embedding audio into our PowerPoints, or are we presenting them through Microsoft Teams?
I went back and forth, and I think, I don't know what's easier, actually. And I don't know. I was trying to maybe not do it on Teams and just keep it in Blackboard and set up like groups in Blackboard. And then in terms of presenting it, you're just basically downloading it. And then the group, if there are 5 people in a group and all 5 of them download their PowerPoint into whether it's a discussion board or however we set that up, then you're going to have a certain amount of time where you can go in and access the other 4, review, watch, their presentation, their PowerPoint, and listen to it, and then make comments and things like that. So I was thinking that would be the easiest way to do that would just keep it all in Blackboard.
Okay, gotcha.
So what do you all think? I mean, I don't want to make things more difficult than they are. That's, to me, that seemed like the kind of the easiest thing is just to, you know, one place to download it, one place to make it accessible to everybody. So, but if when you get into it and you still have questions and it's if it's complicated, just send me an email and you know, we'll work through it. I'm sorry, my cat just walked up behind me and they've got all their nails and decided to use my back leg, use my leg as a scratching post. So I was a little startled there. Anyway, you ready to get started? And all right, so today we're going to talk about coping with dying, and it's kind of divided into two sections, but it will all flow as one in hope. So coping with dying, we're first going to talk about a little bit about sort of the individual, you know, how individuals help each other in coping with dying. And sometimes that takes individuals with special skills in terms of, you know, you may need, obviously you're going to need a physician. And even though that this person is in the dying or terminal phase of whatever illness they have, they still need a physician, or in a lot of cases, a nurse practitioner, but someone who can prescribe medication, someone who can write for particular services. So there still needs to be a physician involved. And another type of an individual skill that is, you know, possibly needed would be a lawyer or somebody from a legal perspective. Things have loosened up a little bit in that. Of course, a will, an actual will, last will and testament, that has to be done by an attorney. And I know people have done those online and gotten them, but for the most part, if you want a will, you need to see an attorney. And does everyone know the difference between when we talk about a will and a living will? Does everybody know that that's a very different thing? A living will is something that everybody should have, basically. Everyone should have something written, an actual living will, and there are drafts of those. We have one that we give out to patients that's from the Kentucky.gov website, and it's a kind of an official document that they can get notarized, or they can have two witnesses sign it. But a living will is something that where this person is saying they what their wishes are in terms of if they are in a situation where they can't make decisions for themselves, what they want done. And the way it's worded is, I'm gonna shut my door real quick. I'm sorry. My dog is barking. So a living will is if you say, if I'm incapacitated, here's what I want. Here's the person I want to make decisions. First of all, you can designate someone that says, I know this person has my best interest at heart. They know what I want. We've had these conversations. So here's the person I want you to talk to. But then it also goes on with some very specific questions about hydration and nutrition. And the way that those are worded, it is, if I am at a state where nutrition and hydration is, my condition is permanent and irreversible, do I want artificial hydration? Do I want artificial nutrition? And things like that. So what that does is takes the burden off of family and friends from having to make those decisions. You don't see them as much in the news, but there used to be lots of, not lots, but there would be these occasional court battles, and things come up where a person didn't have those kind of things, and family members would fight. And there'd be court battles, and in the meantime, this person is sometimes, you know, for a very long time kept alive artificially, when the argument is this is not what they would have wanted, or this is what they would have wanted, and it's families fighting. So that's the difference between a will. A will is what you write when you say, when I die, I want so-and-so to get my house. I want so-and-so to get my car. That's a will. A living will is more about who's going to make decisions for you and what decisions you want to be made. Does anybody have any questions about those, about the differences of those? So for a will, you're going to want a lawyer. For a living will, not so much. We also give out, I don't think I have a thing on it here. We also have a thing that we give out that's a power of attorney. Some people will go to, if you're talking about a healthcare power of attorney, you can sign those. We can give those out at the clinic. If you're talking about what's called a durable power of attorney, where I'm saying I'm going to give someone permission to access my bank account and to make legal decisions for me, that's a durable power of attorney, and that usually does require an attorney, because that's just a little bit more involved. So we're going to talk a whole lot more about those things. We have a whole section on legal issues around death and dying, because there's plenty, but that's just sort of a basic. When you're talking about different people that enter into someone's life at the time that they're dying, to help with things, so sometimes there is need for that, a legal entity to come in and help with things. One of the other specialized people that may be in the home or in the hospital or where in a nursing facility, wherever this person is some sort of a nurse to administer IV fluids at home, because you know, we like people, or maybe we don't like, but a lot of people at home, and so that involves having someone in the home with more specialized skills, more specialized training to keep that person there. And of course, a social worker. So a social worker can be available to help basically coordinate all that other stuff. So a social worker is going to be in there helping with whatever community resources there are. And that may be assisting with legal stuff. I know I do that a lot. We have a lot of patients who, you know, who don't have a lawyer on retainer or can't really afford one. So we're sort of community to try to find them some legal advice or legal counsel. You know, it comes about when you're talking about anything from a legal standpoint, kids, what to do with, generally people have a will, or if they don't have much, you know, we try to counsel them on getting a will, but people a lot of times will just die without one. But a living will and a POA and that kind of stuff, we really try to encourage. But in the end, it's up to them. But anyone really, you know, there's that level of individuals with some special training that can come in and assist people, but then really anyone, regardless of what kind of special training. And again, we go back to, I'm going to assign homework of one of these days of the class watching The Waltons, because it's one of my favorite shows to refer to, and no one knows what I'm talking about anymore. But on The Waltons, it was one of these families, this generational family that, you know, lived on the mountain and took care of each other. So of course there was no one, for the most part, that had special training in any of this. They just did it. There was probably Doc, somebody who, you know, brought his black bag and came to the home when somebody got sick. But for the most part, it was the community, it was the family, and, you know, not necessarily anybody with special training. So, you know, the majority of care, even today, is provided to the dying person by someone who isn't necessarily skilled. And, you know, even, you know, like for me, when we see patients in the cancer center and they're coming from home, it's strictly outpatient. You know, obviously our patients are hospitalized and go to rehab and do all those things. But when we see them, they're coming for an outpatient visit. So they're always, well, not always, but if they've got someone at home, or if they've gotten to a point where they need assistance, more often than not, that is somebody that is a family member. It's a spouse who comes with them and assists them and is talking about, you know, how did they do after this last chemo? Of course, the patient will talk and tell you, but then they'll also, you know, the family member will chime in and say, you know, they seem a lot more fatigued this week, and they seem a lot more, you know, or they seem a lot better, they're eating better. So there's a person in the home that's providing this care that isn't skilled necessarily in any way. Could be family, friends, neighbors. You know, we run into that a lot. I have a lady right now, God love her. She had cancer. She was first diagnosed, gosh, it's been like 3 or 4 years ago. And she really doesn't have a lot of family or friends. She has one son who she didn't want to tell initially. She finally told him, and I kind of understand why she didn't want to tell him. He's proven to not be a very helpful caregiver. Don't know what the history with mom and son is, but you know, where we are right now, that's kind of the case. So she really doesn't have anybody. So anytime she comes up, she's reoccurred now, and so she's back in treatment. She is not able to ride a regular bus, and she can't ride in a cab because of just she uses crutches and other issues that don't have anything to do with her cancer, that she can't sit down in a cab. So it's kind of always an issue with her trying to get stuff coordinated, trying to get her to places, and she's very lonely. And so, you know, she doesn't have family. She doesn't have a lot of friends and neighbors that she relies on. And the first time she had cancer, she got very involved with Gilda's Club and had a really great support network there. She could get there and she would go there quite a bit. Well, their doors are closed right now. So that has not been something for her. So a lot of when she comes in, a lot of it is kind of us stepping in. We've had patients tell us this, and she's one of them. We are her family and friends. You know, she comes to the cancer center, we're her social network. So we do a lot of troubleshooting what her needs are and what she needs at home. And then just kind of being her, she has us all on speed dial. So, you know, it's hard because she doesn't have anyone else to call. So, you know, if you need to talk to somebody, we're kind of it for her. But I digress. The norm and the hope is that that's family and friends that are in there helping her sort out her transportation, helping her, you know, if she's having a really bad day, helping her get through that. So in terms of what a dying person needs or wants, or, you know, when you're a caregiver and you're put into that position as a family or friend or acquaintance, you know, you don't really necessarily know. We're not, in general, we're not trained to do this as individuals. You know, you know that it's, if you have elderly parents or young children, you know, you're going to have to take care of them. But in terms of caring for a dying person, more often than not, it's something that comes at us and we're not really prepared. So Dame Cicely Saunders is a woman. It's a name you'll hear a little bit more as we go through this. She is generally considered the mother of the modern hospice movement. So she sort of birthed this whole idea of how do you take care of dying people, and how do you she didn't birth the idea, she birthed the formalization of that idea, which became the modern hospice movement. So what she talks about in terms of what is it that a dying person wants from a caregiver, and some of the things that she came up with was, you know, I want you to help me. And, you know, and by that, I mean, minimize my distress. Help me, make me feel better, make me, you know, help me in whatever way that can be. Do I want you to help me physically? If the caregiver is a medical person, help me. I want you to make this pain go away. I want you to make me less nauseous. If it's a chaplain that comes in, you know, help me feel, you know, make my heart feel better. Help me talk about why God's doing this to me. Help me. a social worker or counselor, help me talk through what it is I need to talk through before I die. So help me with those things, because I don't know where to start as the dying person. I don't know where to start. I need you to help me. It listened to me. They want to be heard. And, we've talked about this some, that when someone receives a terminal diagnosis and we consider them the dying person, and we've talked about, well, when does that start? When do you become the dying person? And, it's different depending on that trajectory that they're on. And the sometimes, especially if it's an elderly person, for some reason, we quit listening to them. They're the patient. They're dying. We talk over them if they're lying in the bed. Well, how is he feeling today? Oh, I think he's feeling okay. In the meanwhile, the patient's lying there and you're talking, and if a physician walks in, I've seen this a lot, they're asking the nurse or asking the family member, and they're not listening or even asking the patient, the person lying right in front of them, wide awake. We don't listen to them. So that's something that the dying person or that individual says they want, is I want to be heard. I want to tell you where I'm hurting, if the pain is physical or spiritual or what it is. And let me have a say in how this goes. Again, don't talk around me about what we should do next. Talk to me about what we should do next. And make sure I understand. And don't leave me. Stay with me. Give me your presence. We've talked. People become really I know it's going to sound strange, but people become kind of selfish. I just don't know what to say. I wouldn't know how to act. I wouldn't know what to do. Well, I don't want to get in the way of family. That has nothing to do with the patient. When you start hearing those excuses, that doesn't have anything to do with the patient and what that person needs. It has to do with this caregiver, this person's discomfort level. If you have a friend or a family member who has this diagnosis, they will tell you that they see especially now in the age of digital texting and Facebook, and sorry, the cats are fighting. They'll get a lot of texts. Thinking of you, how are you doing? Which is great, but people feel like that absolves them of anything else. So in the meantime, this person can be quite alone, where they had a wealth of friends and family before this diagnosis or before this became, a terminal diagnosis. So, don't leave me. Don't. I'm still all the things that I ever was to you. I'm still your tennis partner. I'm still the person who likes to talk politics with you. I'm still your aunt. I'm still your cousin. And, to totally shut that all out it's very lonesome, very lonely. So the other thing we'll talk about in terms of the type of care that caregivers are often called upon to provide. So there's 4 dimensions, 4 different types of care. The first one being physical. And so, of course, that's pretty obvious. But what it means specifically, the biggest one, and the one that patients and that people who are dying or who have that illness, and when a lot of us, when we think of death, that we're afraid of, is pain. So one of the big things is the biggest thing, and the probably one of the first things is we want to make sure people aren't suffering and don't have physical pain. Whether that means pain control in terms of medication and, or withdrawing certain medications or withdrawing things. We can help the pain by medicating it. Sometimes we can help the pain by taking medication away if that's what's causing the pain, particularly when you're talking about a cancer patient and some of the medications. So when we talk about pain, 2 different types of pain. So you have acute pain. And so when you say, oh, you want to eradicate the pain, you want to take the pain away, it's important to know, pain is it's basically something we have to have. It's essential and it helps us. So, being in the room with the doctor and a patient comes in and they ask them, one of the first things is, do you have any pain? And, oh, my hip's been hurting a lot lately. Well, that's important information that gives a physician information. And so it helps them sort of start with diagnosis and start with, and a lot of times pain is what, you'll hear people say cancer doesn't cause pain, but sometimes it does. And pain is a lot of times the thing that will prompt a person to seek help. So without pain, there are people who have, and I forget the name of the illness, but there's an illness where you don't experience pain, and it's very dangerous. So, if you don't experience pain, you don't realize when you put your hand on the stovetop and the burner's on, and you don't feel the pain of your hand burning, but your hand's burning. And, so obviously you want that acute pain in that situation to tell you the split second you touch that hot stovetop to take your hand off. Because even though they don't feel the pain, the 3rd-degree burn is still there and it's gonna, cause lots of troubles. So the same is true with illnesses. So when we talk about relieving the pain, taking the pain away, you may not always take it to that level. Chronic pain is really not something that serves a purpose. And it is the kind of pain that we're talking about here when we're talking about an individual who's dying. It's that pain caused by, depending on what they're dying from, that chronic pain of cancer pain, a tumor growing, or the cancer being in a bone. With the heart disease, it's the chest pain. It's the physical pain that goes on at a steady rate. It's not like an acute pain. It is a steady, chronic pain that serves no constructive function. That's the kind of pain that a physician or the professional, medical professional, and all of us really want to eliminate as much as we can. That's the kind of pain we want to get rid of, and the pain that most people fear when they are afraid of dying, and the pain associated with it. So identifying pain, we all have different pain tolerances. So we've come up with different ways over the year, because you can walk in a room and say, how, are you in pain? And how much pain are you in? And you're going to get a wide range of answers from somebody, depending on what that pain is and how that person perceives the pain. So what we're looking for, though, is that person's perception of pain. It's not maybe how you would feel about the pain or what it looks like the person is in, because sometimes somebody can be sitting there and smiling and joking with you and be in incredible pain. So I don't know if everybody's seen this pain scale. You've probably seen it if you've been to the doctor, because it's plastered usually all over. And this is kind of it's an easy way, and we say to people on a scale of 1 to 10, 1 being basically no pain at all, you're not really feeling much, 10 being the absolute worst pain you have ever felt in your life. On that scale of 1 to 10, where are you? And people tend to get that. People tend to say, well, it's probably not the worst, but it's an 8, or it's a 7. And it kind of helps the medical professionals understand, and anybody understand what that is. And if you can track that for that person, in their chart, you will say they rated their pain at a 6 today. They rated their pain. And if you look back and see, they've always rated their pain at about a 4 or a 3. So now all of a sudden it's a 6. And, you might not necessarily think, oh, it's a 6, we need to do something. But in this person, you might say, that's a significant jump for them. And then you have people who come in and it's always a 9. Oh, it's always it's an 8, it's a 9, it's an 8, it's a 9. And if you drop to 6, you're doing something right. So it's very individual to that person coming in and what their pain is at any given time, their perception of their pain at any given time. Any questions about that? So managing pain, and there are some concerns about managing pain with medication. I'll go back there because apparently I didn't list them. There are concerns about managing pain with just medication, and any patient, especially if they are in that dying, that terminal stage where they're still active and they still want to do things. So they don't, the first thing they'll say, two concerns generally that we hear when we start talking about managing pain is, I don't want to be snowed. I don't want something that's going to make me feel like not myself, or make me want to sleep all the time, because I still got things I want to do. And I don't want to get addicted. So two very real concerns. There comes a point with the pain and the addiction discussion where you talk to patients and say, your risk of becoming addicted it's not irrelevant. It's less relevant to us than keeping you out of pain. And the amount of pain that, particularly cancer pain and a tumor, causes, you have to increase pain medicine at a regular basis to continue to control that. And it's needed. It isn't, you're not taking pain medicine to feel better, to feel good, to feel happy in that way. You're taking it to feel normal. So it's a real tricky conversation with people, particularly people who have battled addiction. We have a lot of people who come in who, I'm 10 years sober. I don't want, this kind of narcotic. So it's a lot of, some skilled discussion and knowledge about pain medicine to get them where they need to be and be pain-free and not be worried about addiction. And we have a lot of people who come in who are full-blown addicted, and it's about managing the pain medicine in other ways that that we have to do drug screens every time they come in to make sure they are the ones using that pain medicine and not selling it. And yeah, it gets a little tricky in that way. But the bigger issue is people not wanting to feel like, well, yeah, okay, I'm in pain, so just knock me out. If you've got small kids, you're still trying to work. If you still want to go out and do what you do, you don't want that. You want your pain controlled, but you don't want to be snowed. So those are some issues with dealing with it only with medication. And so we try other things, and then you always kind of go back on the medication, but there are other things that can be tried to manage pain. Guided imagery, biofeedback. We do a little bit with meditation. I'm not as familiar with the biofeedback, but of course the guided imagery. We have our expressive therapist at the Cancer Center does a lot with this kind of stuff and finds it very helpful. We also employ massage therapy, and they're not, they're massage therapists, but they're trained specifically in massage with cancer patients. So it's a lot of dealing with that. And I don't know how many of you have heard of Reiki or know what Reiki is. It's not touch, but it's a non-touch form of, it's always hard to explain if you haven't had it, but our massage therapist is also trained in Reiki. And it is more of an energy field sort of therapeutic intervention. And people find that to be very helpful managing some of their pain. Doesn't take it away altogether, but some of these ways of, oh crap, sorry about, not sure what happened there, except that my phone, I'm sorry, are you all, are you all there? That was weird.
Yes.
Okay, I don't know what that was. I'm sorry. I had my phone off, but yet it rang. Anyway, so try a lot of these different type of things, and medication is all still very much the probably the biggest tool, but it can be aided by these other things. Pain, of course, is probably the biggest thing and the thing that most people worry about, but you also have lots of other physical symptoms to deal with depending on the diagnosis. And nausea, diarrhea, constipation, and vomiting, all of that, those sort of other symptoms, symptoms of whatever disease and or symptoms of whatever medication or treatment that you're getting. So, we want to try to control those things too. And sometimes that's when you look at things and say, we need to take this medicine away. So it isn't always just giving more medicine. Sometimes it's removing medicine. And that can be tricky too. If you're treating someone and this is your treatment and we're hoping that this prolongs your life, and then a couple of weeks in they're having these horrible symptoms, so you say, well, we're going to have to stop that. That can be very scary, and you feel very defeated as a result of that. Weakness, dehydration, loss of appetite, those are all other physical manifestations of particular diseases, and particularly in the dying phase. If you are dealing with someone who is actively dying, they don't want to eat. They do start to dehydrate, because that's, when you're in that, when I say actively dying, it's more of that, within a week or within a few days or sometimes hours, where that, the body starts to the body doesn't need food anymore. Body doesn't need to take in water and nutrition and that type of thing the way that it did, because the body's starting to shut down. And that is one of the hardest things for families, is people not wanting to eat. That's just kind of something that we do as humans, as caregivers, as we want to feed. If you eat this, you'll feel so much better. You have to eat, you have to drink. And at this phase in the dying process, they just necessarily, they don't. That's in the very acute phase of dying. In the early phases of someone with a terminal diagnosis, sometimes you do have to tweak things, because you do want them to eat. You do want them to stay hydrated. So just varying degrees of where things are. Psychological dimensions. That's, we're talking about the 4 dimensions of dying. We talked about physical, psychological dimensions. Again, we talk about people pull away. When you find something out about a friend or a coworker that they've gotten this diagnosis, and you, oh boy, I want to go see them, but I just really wouldn't know what to say. I wouldn't know how to act, so you stay away. So very psychologically sort of demoralizing for someone who feels like they're being abandoned. And, there really is no right way to act and nothing to say. You're not going to take that away. You're not going to make it all go away, but you can certainly make it better. I think I just said that. You can't make it all go away. So, again, I think that's sort of human nature, is you want to be the person to say, I said, I said this wonderful thing, and it had such power and meaning, and it made such an impact on this person, and they're okay now. That's just not reality. You're not going to make it all okay. And this is important. This is important for everyone, but it's particularly important for social workers or people in the helping and caring professions who want to do this on a professional basis and a regular basis. You have just got to get comfortable around uncomfortable emotions. And sometimes that's work. And it's an effort, but it takes a lot of sort of getting to know yourself, and getting comfortable in your own emotions. That's why classes like this can be helpful, because it starts to get you thinking about that. One of our first exercises was writing our own obituary. That can be uncomfortable, to start thinking about, oh my gosh, well, if I do the math, and I live to 85 or 90, that'll be such and such, and what will the world be like then? What will my life have been like then? And that can bring up some uncomfortable things, but you have to get there, and you have to be able to sit in those emotions and sit in other people's emotions and not feel like you're going to fix it. Mostly you're not going to fix the emotions and the pain. You may help, and being there and listening and all of those things, but you don't have magic words. I don't care how much school you go to, get your master's, get your doctorate. You don't have words to magically fix people. I know it's a shock to some people when you decide to go into social work, because we go into social work because, we want to make everybody feel better, fix things, and sometimes that just doesn't happen. Just being present, and that, when you start to overcome those uncomfortable feelings and that need to fill the space with something, and you can just sit and be present and listen, that's what mostly that person probably needs, is just for someone to hear them and to be there and to not be afraid of them. That's hard. It's hard to sit in silence. But, again, it's something that you have to learn to do. Some of us have that natural gift to be able to do that, and other people just don't. And it's practice. One of the other things that, from a psychosocial, psychological aspect of things, if you're acting as a social worker working with a dying person, is to kind of start and help with that life review process. And it can be a formal thing. It can be a very informal thing. And, we've had people do that, particularly with hospice, with the help of a hospice social worker, do videos, like life review videos, do picture books, do, whatever medium they want to use. And sometimes it's just chatting, and sometimes it's just listening to the person talk about their life and things that they did in their life and what they will miss and who they will miss and what was good in their life. So it can be just an informal conversation. Touch is always important. Again, it's that thing of, the person can be lying right there or sitting right there in the room, and you want to kind of talk around them, and afraid to touch. And they really very much need that when appropriate. Here we are in the land of COVID, and we talk about people, very truly being isolated and dying alone in a hospital or a nursing facility, and they get very little of all of these things. They're not getting much of it, the psychological assistance, and particularly, touch obviously is physical, but it can also have psychological ramifications. When I have patients come in, and I have some that, we're big huggers. I hug. I always ask, particularly in the beginning, can I hug you? Or can I, you okay with I touch you? But more often than not, and it's really hard. And you'll see people, everybody kind of go in, and then you're like, I can't. So, we have virtual hugs from the doorway, but it's really important to be able to touch, and to not be able to do that right now is really hard. And social dimensions, the third dimension, dying, so is kind of, where's my place now? Who am I now? And this happens when people get diagnosed, And it happens when people are given that terminal diagnosis, is that, now I'm what I'm at. What is my purpose? Why am I here? And who am I now? Am I still my kid's mom? Am I still my husband's spouse? Am I still am I still a elementary school teacher, if that's what you did for a living? And, who am I now? I'm just waiting to die, or am I still going to be productive? Those are big questions, and sometimes hard to answer. There's a term with Alzheimer's patients that when I worked for hospice, for whatever reason, we had a lot of Alzheimer's patients, and I really enjoyed working with them. And once I got over how you talk to them, how do you engage and work with someone who has Alzheimer's, and the term walk in their world kind of helped snap that into some sort of, that made sense, because when you are working with someone who has Alzheimer's, you're not gonna alter, and it's a lot of it is working with the family members too, who of course it's so much harder, that you want it like a big thing is an Alzheimer's patient thinking, she thinks I'm her sister. If a daughter comes in to visit her mother with Alzheimer's, and the patient doesn't recognize her, doesn't know her, doesn't know that she has a daughter, and thinks this is my sister, whomever. And that's very upsetting, of course, for the daughter to not be recognized as the daughter. And so the impulse is to, no, Mom, I'm not your sister Sally, I'm your daughter, Karen, and to do that every time you come visit, to have that, to sit down with Mom. She doesn't know who you are. She thinks your sister Sally, and to have that constantly for that daughter is just gut wrenching. And it's hard to get them to the place to say, just be Sally. It's hard, but if you're really here for that hour to visit with your mother, and to give her some peace, you really have to be in the world that she's in now. And in the world that she's in now, she doesn't have a daughter. She has a sister, Sally. And that's a big ask. But much easier for me as a hospice social worker coming in than it is for the daughter. But whoever they think I am on any given day, and nothing that you talk about today, when you go back a week to visit, it's a whole new thing. You're introducing yourself all over again to that person and having that conversation. So you have to be in their world, and you have to be right there, right then, in that moment, because you're not building a relationship. You're not doing anything. They're not going to remember. If families would talk, take a person out of a nursing facility and on an outing, took them to their favorite restaurant because it was their birthday. And you can't go back the next day and expect to have a conversation about that. Or, in a week, say, oh, remember, Mom, when we went and we ate at, the steakhouse, and it was your not gonna, but so they're not going to be able to remember that and have joy out of that memory. So again, that's hard. That's hard for a family member. But for that hour that they were at the steakhouse and they were with their family, they were having that was a good time. So that's hard. You have to make that person feel good about where they are at that very moment. If you've never worked, Alzheimer's is working with patients and families with Alzheimer's, because the whole family has it. I mean, it really truly is an illness and a disease that just takes everybody with it. But anyway, whole lot to unpack there if that's an interest that you have. So kind of talked about this. A person in general, no matter what it is that their terminal illness is, they still need to identify as the roles they've always held. They are still a child. They are still the mother to their children, and there are still all those things. So that struggle with place and who am I, there's still those things, and sometimes they just need to hear that, and need to be treated like that. And if it's my sister who's got a terminal illness, she's still my sister. I'm still going to give her hell when she does stupid things. And, that's probably how she would want what she would want me to do. She doesn't get a bye because she has whatever illness or is terminal. And finding meaning and purpose. We have a young woman, and again, I know I apologize for this all the time, I'm going to stop, but all my references are oncology, particularly breast cancer patients. So those are my examples. But we have a woman, and her name is Laura McGregor. She is a public figure now, so I can say her name. She is a stage 4 breast cancer patient. She has been stage 4 for some time. And, she's a mom, she's married, she's a young woman. When she became stage 4, she got very involved and started a foundation called Hope Scarves. And they've been around and very active for, gosh, I don't know the timeline of when she became stage 4. And stage 4 in the breast cancer world is terminal. You can be stage 4 in other cancers and it not necessarily be terminal, but in the world of breast cancer, stage 4 disease is treatable, meaning they still get treated. It is not curable. So that's where Laura is right now. And not long after she became stage 4, she started Hope Scarves, and it's sort of spread, and it's kind of a national thing now. And it's for breast cancer patients. Actually, I think they've expanded it to any cancer patient, that you donate a scarf. So if you were a cancer patient and you have a particular scarf or a special scarf that you wore, you can either donate one that you've used, or you can buy a new one and donate it. And you write your story, and your story is attached to the scarf. So then it's passed on to the next person who gets that scarf, gets your story, and can either pay that forward or pay it forward with a new scarf. So it's a way of, then they do other things too, and they do fundraisers and things like that. That's how she found meaning and purpose. She's still very much, her child's parent, and she's still a spouse, and she's still a friend, and she's still all these things, but she's been able to find some particular meaning and purpose to her special situation, and has really helped a lot of people, and probably helped herself a whole lot in the process. And the final and fourth dimension would be the spiritual dimension in terms of those 4 dimensions. You guys, you're searching for meaning. We all, hopefully we're all kind of, searching for meaning as our life, and especially right now with everything going on, you search for meaning in your life and meaning in your death, because that has now become a very real, if you've got that terminal diagnosis, it's a very real thing. It's not an abject, like, well, yeah, I'll probably die someday, or, if I die, you hear people say that all the time. And well, if I die, and I always kind of put down the urge to tell them it's not if, because it's going to happen. But people don't want to hear that, especially over drinks on a Friday night. So, but when you do know that for sure, that that's what's happening, you start to really think about it a little bit different, and you start thinking about, and by spiritual, I don't necessarily mean that you all of a sudden, oh my God, I've got to get to church, and I've got to make amends. I got to do all these things that I haven't done in my lifetime. Maybe that is what you do, but it kind of more that spiritual dimension is the meaning of life type things, type questions that come up, and how to make meaning of your life that you're still living, and the impending death that is coming. And so if you're that person coming in, and you don't have to be a chaplain, you don't have to be a spiritual leader, you can still discuss those beliefs. You can discuss it through music and books and whatever kind of sacred objects there are for that person. Anybody can have those conversations with someone who's approaching the end of life. And they can actually be more impactful than a trained spiritual leader coming in and doing that. There's places for all of that. It's also sort of a time, this fits in the spiritual realm of things, that magical thinking. Everybody maybe heard that term before. It's sort of a basic, we think about it a lot with kids, that, small kids tend to think, that whatever is going on in the world, they somehow caused it. And good or bad, that it was their fault somehow. I didn't clean my room when my mom asked me. And, so then because when she left that day, she got in a car wreck and was killed. And in this child's mind, they caused that because they didn't clean their room when mom asked. That's magical thinking in terms of that young child magical thinking. In this way, what did I do to deserve this? I'm a good person. I've lived a good life, and I've treated people well, and I've got 2 small children, and I'm married. I just started a business. I'm doing everything right that I'm supposed to do, and I get terminal cancer. What did I do to deserve this? When, the person this person I graduated from high school with, who has done nothing but, rip people off and do this really bad person, and they're not dying of cancer. That's a very angry spot to be in. And, the blaming God, blaming whomever that it is that you feel like has kind of caused this to happen to you. So those are the 4 dimensions: physical, psychological, oh my God, social, and spiritual. Sorry, I had a brain fart there. All of those come together. We think a lot, of course, mainly as of the physical aspect of dying, but there's all 4 of those that come in when that person is going through that, having been given that terminal diagnosis. So when we're talking about caregivers and taking care of someone who is dealing with caring for a caregiver, how do we help that person, and what's out there to help that person? The answer is not a lot. It's just not built into the way our society works. FMLA, Family Medical Leave Act, which is something that you can apply for yourself if you're sick, or for a loved one. If you have someone in your family who's just been diagnosed and you're their caregiver, and you're going to need to be available for doctor's appointments and things like that, you can apply for Family Medical Leave Act that says you can take off. Your job will be safe for this set period of time, 6 weeks, however long that is. It's not going to pay you, but at the end of that 6 weeks, in theory, you still have a job. And let me tell you, I just tried to apply for FMLA because my dad, I'm constantly taking him to doctor's office and stuff. It was really hard to do. It's not an easy, there's lots of paperwork, lots of hoops to jump through. And so this is something, going back to that, in terms of who the helpers are, and the social worker being the helper, that's something I do it all the time for other people, helping them get their paperwork turned in. But being on this side of it, trying to do it, it's kind of insane, the amount of paperwork they ask for. I finally just kind of gave up, but and it's especially hard if you're not a spouse or a child. So if I happen to be very close to my next door neighbor who's an elderly woman, she doesn't have anybody, and I've sort of stepped in and said, I'll bring you food over periodically, I'll check on you, and I've kind of taken on that role. And as she starts to decline, she looks to me to take her to doctor's office, to doctor's appointments, and I'm more than happy to do that. And then I try to say, well, I'd like to get FMLA, so there may be, when my next door neighbor has, because she has no one else, you're not going to more than likely not going to get that. So even if I am the only caregiver, the fact that I'm not necessarily related to my next door neighbor means that I'm not going to have any kind of protection in that regard. And certainly domestic partners, that's been the laws and rules of marriage and what defines a domestic partner sort of change all the time. Depending on what's going on with the Supreme Court, may change again. So, when you have domestic partners, whether they are same sex, different sex, it doesn't matter. There's a lot of situations where that's not gonna help. So, more on that as we talk about the legalities of dying. So coping with dying, more on like the communities that are involved and what they do. Hospitals, of course. So acute care, the definition of acute care is, think about acute, it's like acute pain, it's in the moment. So acute care is very active short-term care. And that is a hospital. The definition of a hospital, and it's in and out. They're not, you don't rehab at the hospital anymore. It is designed to cure. You're not going to recuperate and heal. And my dad can't quite wrap his head around that. He was in for this surgery a while back, and of course the next day they wanted him to get out of there, and he was still loopy, and so he could not figure out why they were discharging him from the hospital when he still felt so bad. Of course, he was going to a rehab facility, but he just, he said, I should be able to at least get up and get around. And it's like, that's not what a hospital does. A hospital gets you past the acute phase and the acute situation, and then they move you on to somewhere where you're going to recuperate and heal, and then home. So that is acute care. 44% of the US people in the US as of 2010 die in acute care settings, die in hospitals. So that's not what hospitals are for. So we're still having an awful lot of people who are dying in facilities that are set up for people to just be there short term, to get what they need and get out. So it's a little disconnect. So long-term care, when you talk about long-term care, that's more like an assisted living, usually like an elderly person or a disabled person who needs just some minimal assistance. It's also can be a memory care unit, like in an Alzheimer's situation. People can live with Alzheimer's for a very long time. So obviously they're not going to need to be in the hospital. They need to have their needs met. They need to have the care. But so there's a specific, particular situation in a place in some facilities that is just a locked memory care unit. Skilled nursing care it's basically, it's hard now. It's all these designations, but skilled nursing is in a nursing facility. We used to say nursing home. You don't usually say that anymore, but that is where you have a skill, you have a need that requires a nurse, and you need that nurse to be available 24/7. So a lot of times people after surgery, they still have wounds, or they'll still have need for some intense physical therapy. They'll go to a skilled nursing unit because there's a nurse there, but not the hospital. Again, we're not talking of an acute thing. We're talking of a healing situation. So they're going to be there for a little while. And more custodial care is what we used to think of as the nursing home. You go there and then you're going to stay there. That's going to be your new home. And that's where you're going to live. It's not something that is, you're not going to, once you get finished with that skilled nursing, your wounds are healed, that kind of thing, that you're going home. You're in the nursing home. So home care encompasses a lot of different things. It's basically, you can do skilled care in the home, like a visiting nurse. home health aide, nurses can come out to the home. So again, when my dad had his surgery and he went for rehab and physically was able to get up and move a little bit, he still needed some nursing and some skilled care and a little bit of physical therapy. So we had a skilled care. We had visiting nurses come out to the home for a short period of time, and help kind of monitor that. They're not here. The nurse isn't available 24/7 physically. They come out once a week, and you can call them if you need them. So just a little step down. Usually available 24/7 by phone, but not in person. And he, physical therapy, that kind of thing can be done like that in the home. And it's meant to keep people out of the hospital. And that's the whole thing with the acute care setting with the actual hospital, is they don't want you to come back. Medicare is actually set up now that to penalize hospitals if a person is readmitted within a certain period of time. I think it's 30 days. So they want to keep people out of the hospital because that's their goal. Hospice care. So it's a concept, not a place, although it can be a place. So when you think of someone going into hospice, it isn't necessarily that they're leaving their home. In Louisville and in most cities, we do have an inpatient hospice. It's down on Broadway, sort of near the Norton complex. It's at Broadway and Floyd, and it is a unit of that building, and it's a hospice unit. It's an inpatient hospice. Although the majority of people who have hospice stay in their home, and the hospice team comes into the home. So, but they accept death as the final stage of life. They don't, it is still being alive. They don't hasten death. So you'll hear rumors and stories, and they don't postpone death. They let it happen. Their goal is comfort, and quality of life. They're not gonna do anything that speeds that along. And it treats the person rather than the disease. So I know our doctors at the clinic, and you'll hear them talking. It's not that it's how they have to think. Again, the physician that I work with is brilliant. I mean, she's, in terms of breast cancer and the treatments and the specifics of a particular patient's type of cancer, none better. That's where her brain is. So, she will talk about, so-and-so who has, this very specific type of, it's estrogen positive, but it's HER2 negative, but it's got this feature and that feature. And I think we can still give this drug because it just came on the market. I mean, it's incredible. And sometimes, myself and the nurse that works with her, we have to, this just happened yesterday, where this patient, but she's like, but we haven't tried such and such yet. This person is, she's there, she's at the end, and she's tired and she doesn't want to do it. But Dr. Riley, that's my doctor, she's like, but we haven't tried this, and then there's this, and then there's this. And we both looked at her and it's like, Dr. Riley, she doesn't want to do all that. She wants, and it's hard, she's got this husband and they have, this grandbaby come in, and she wants to be able to enjoy her family. And, we have to pull her back there sometimes. And it isn't because she's not a very caring person and loves her patients. She absolutely does. But she's treating that disease. That's her job, is to see this disease and to throw everything she knows to throw at it. When hospice comes in, the disease is still there, and in some respects you have to work around that, but they're more concerned about, okay, so you're to this point, your disease, your cancer, yes, it was this type of breast cancer, now it's gone into your bones, and maybe it's in the lining of your brain, so that makes you really weak. So we're going to make sure that we try to do things and keep you active so that those symptoms don't overwhelm. So that's what hospice is doing. They're monitoring if it's in the bones, how's the pain? They're going to be checking on that. They know exactly what medication. To to provide for the bone pain to make that feel better. So, and it can happen anywhere the patient is. So if they're at home, their hospice can be there. If they're in a nursing home, assisted living, inpatient hospice is generally reserved for patients truly at the end. So where you can best guess that they maybe have a week or two at the most. They can be in an inpatient setting. Sometimes they'll move patients into an inpatient setting if their pain is out of control and they can't manage it in the home, or whatever symptom is out of control. They'll move that person into the inpatient setting long enough to get things back under control and then send them back home. We had patients, I mean, because you really do, it's where they are. And you know, we admitted a patient once that was living out of their car, and first order of business was to find them someplace to be. So in that situation, you know, we went out, we admitted the patient, she was living in her car, and as the social worker, I was the preeminent team member for her, because she was doing okay physically. She didn't have a lot of pain, so the nurse was there, and the nurse was doing her thing. But the number one thing in that situation was that psychosocial, was that social component of finding her someplace to actually live, to actually stay and live. And she wanted that. If she had said, I want to live in my car, you know, we figured out a way to treat her in her car. She didn't want to live in her car, so we found her some other place. But all right, so just a brief history. I know this is a lot of words on this page. Again, we talked about Dame Cicely Saunders, the mother of the modern hospice movement. And she started working in 1948 in London and sort of developed that first hospice, St. Christopher's Hospice. She introduced the idea of specialized care in the US in 1963. And the first legislation was passed. Hospice legislation was passed in 1974 that would provide federal funds for hospice programs. It's never been enacted. Yay, America. Congress includes a provision finally in 1982 for Medicare, what's called the Medicare Hospice Benefit. So just in 1982 did we finally get hospice as kind of as we know it, where it was covered in Medicare and insurance. So it hasn't been around that long. So the hospice Medicare benefit, if you ever work in hospice, this is something you'll hear constantly. This is how hospice is pretty much paid for. So in 1982, it allowed Medicare to pay for hospice services. Private insurances quickly followed. That's pretty much the way things work. If this is the way it started, this is the way it still is. It's what's called a per diem. Per diem means per day. So Medicare says if you put a patient on hospice, we are going to give you X number of dollars a day from the day this person is admitted until the day they die. I don't know anymore what that per diem is. It used to be like $150. I don't know. I'm sure it's gone up. I hope it's gone up. So what that means, if you admit this person on Monday and they die on Friday, you know, you're going to get 5 days worth of per diem, $150. So whatever that person needs, when hospice takes on a patient, they take over, they kind of become the insurance company. They take over the care of the person for whatever that diagnosis is. So if it's a cancer patient, they generally have to stop whatever treatment they're on. So they're not going to be actively receiving chemo or radiation if it's meant to cure. Sometimes they'll do radiation if it's palliative, meaning that they'll do radiation to something if it's painful. And hospice will pay for that if it's deemed palliative. So out of that $150 a day, they have to pay for all the medications, all the services, everything for that patient. If something comes up with a patient who's on hospice that's not related to the diagnosis, Medicare continues to pay. So for example, if somebody's admitted for terminal breast cancer, hospice is paying for all the medications, all the services. Then that person goes out and falls and breaks their arm. Hospice isn't paying to have their arm reset. They're not paying for, they're going to go to the emergency room. Medicare is going to cover whatever that is that's related to that. So that's what that per diem means. Kentucky, we only have, everybody's heard of Hospice probably. That is the hospice group. It's just their name, in Louisville. And it's also in E-Town and Central Kentucky, I think. We only have the one hospice in Louisville. If you go to hospice in Louisville, you're with Hospice. And that has to do with the way Kentucky is set up. It's called a certificate of need. It's a whole lot to explain in a short period of time, but it's basically Kentucky is set up to where if you want to open a healthcare facility or organization, you have to prove that there is enough people who need it to support the additional beds, as they call them. So we have a certificate need here, so we only have one hospice, and that's Hospice. If you go over the river into southern Indiana, there's about 5 or 6 hospices. Hospice is also in southern Indiana, but there's also probably 4 or 5 others that have opened up over there. Hospice, which is in Louisville and in southern Indiana, is a not-for-profit hospice. The other hospices that have opened up in Indiana because they are for-profit hospices. So there's a big difference in that, in terms of they still get paid the same way. They still get that Medicare per diem. They still get those services. They're still supposed to adhere by the mandate of what it is to be a hospice. And basically that means they have the hospice team. So they have a hospice physician or medical director. A lot of times the patient's actual physician will maintain that role and be their person, still stay in direct care. But sometimes the hospice physician steps into that role. There's nurses, there's home health aides, social workers, clergy and counselors, and then trained volunteers. So they have access to this whole team when that's all, again, a part of that per diem. They're not paying extra to have a home health aide come out. They're not paying extra for any of those services. Also built in to the hospice program is it requires there to be 13 months of bereavement care after the death of the patient. And we said earlier, when Medicare or insurances, they pay from the day that they admit that person to hospice, they stop paying the day the patient dies. So, but they still have to provide bereavement care to the family and friends for 13 months after that. That's where the difference between a for-profit, not-for-profit hospice can sometimes come in. Without getting too, I don't want to make it political, but when you're for-profit, you have shareholders, you have stakeholders that expect to get profit back from that. So any profit that you make goes back into your programming, but it also goes to shareholders. In the not-for-profit setting, as a rule, there's no one expecting to get money because they've invested. There's no stockholders. So that money that comes in that would normally be considered profit all goes back in to your organization, as does any contributions, any fundraisers with both. So Hospice has a very thriving bereavement care and grief counseling center that is free to families, including support groups, one-on-one counseling, children's programming, and that's all supported by this money that comes back in. you don't have to provide that. That's when when Medicare says, or when that law in 1982 says you have to provide 13 months of bereavement care, it could be a letter every 3 months or a phone call. And so, it could be that simple. It could be that, or it could be a very extensive counseling situation like you see with like our hospice. And I usually have the guy from one of the counselors from the Hospice Grief Counseling Center come and speak in class. So I'm really bummed that that's not going to be something that we're going to get to do. So it's pretty fascinating. It's a fabulous program. And I don't know, to be quite honest, I've asked, I don't know what some of the for-profit hospices, I don't know what their bereavement care program looks like in general, but I know they get a lot of people in the Grief Counseling Center who've had hospice at other hospices that are coming to the Hospice Grief Counseling Center for counseling. So try not to sound too biased, but obviously I am. So one video, just one. But before I do that, well, I'll do that and then I'll tell you what the quiz is. So you'll have to hang around. Let's see. Share my screen.
Why I'd want to work with people who were dying. It must be very depressing. It must be very sad. I think you get to see the power of the human spirit when you work in palliative care.
I just feel very privileged.
What it is it's very real.
You know, the people who are dying, they give me more energy. They teach me so many lessons.
It's emotions, actually. That's what it is.
We look after people who have a serious illness. Up until recently, it would have been predominantly a diagnosis of cancer or motor neuron disease or AIDS. That is expanding. The people that we look after aren't getting curative treatment anymore, so their illness is terminal. What we hope to do is to just make them as comfortable as we possibly can.
And we offer counselling and psychosocial support around the impact of illness, the changes that are happening, and we might help around financial issues, practical issues, but a lot is around communication, around preparing people for what maybe is going to happen, around the impact of care, the changes that have already happened as a result of illness, and an opportunity to express how they're feeling.
So as people come to the end of their lives, it's often a time where they're upset, they're distressed, or some of their family members might be upset. And so I'm a person they can come and talk to about their internal life, how they feel and how they think, primarily within themselves.
So one of the things when you begin to work in palliative care is you realise that the majority of people you meet will die. And they will die within the coming days, weeks or months. So you know, and you begin to work towards that end with people. Last year in our inpatient unit, about 270 people died. So it's a very normal part of our daily and weekly work life that somebody has died, and it's somebody that we've worked with or somebody we've developed a relationship with. But you develop it at a level, you're not emotionally connected to them the way you would be a friend or a family member.
There's always a touch of awe about somebody dying, because it is such an ultimate moment. There is no coming back from it. There's no rehearsing it. There's no doing it over again. So I think depending on our own philosophy or belief system, you know, it will be a moment. It is a sacred moment.
And sometimes on those days, it can hit. And it might be because it resonates with another loss that I've had before, or it might be because of the relationship that you develop, because I think all of this work is about relationship. I don't know that I'd say it overwhelms me, but I think there are times where the emotions definitely come to the fore and you need some space and time. It's not like you can come out of a room and say, that's fine, I'm into the next person. So you do sometimes need to take a bit of time.
Having a conversation with a mother in relation to her son, who would have been 8 years of age, was being tube fed and he was actively dying. And because of the feed, it was overloading his system. So it was causing him his problems and he was going to have an uncomfortable death if it continued. So I had to speak to his mother about stopping his feed. And like, to speak to a mother about stopping feeding their child is, you know, for the mother, she couldn't believe I was suggesting that. And I had to explain in palliative care and in hospice care, you're constantly, it's balancing the burden of something and the benefit of something.
Oh, I've cried lots of times, you know, when a patient has died or, you know, something has been particularly difficult. I think we all do. And I think here it's acknowledged that that's okay. It's okay to cry and it's okay to be upset and to feel. Because I don't think, again, no more than you couldn't do this job if you didn't feel for people, you know.
Sometimes that hits so much, you need to just take a few minutes, and your colleagues are really good for debriefing, just allowing you to say, actually, that was tough, or I really felt that, or my heart goes out to that person. But our professional piece has to be there as well. But I think there is a great teamwork and support across the range of colleagues.
Love has its limits as well, that, you know, we have to be quite disciplined in how close we get to people and equally how distant we are from people.
You know, if I've had a difficult day and I go into the office to write up my notes, somebody might notice and say, Anna, what kind of a day had you? And it might be the day that I had, you know, I was touched by whatever was going on. Or I'd have noticed myself or somebody else not, they might come in and I said, oh, what kind of a day? And they go, that's what happened. So it's that sense of being able to take it back out of the box, as it were, and look at it at another time. And I guess that's what keeps us hopefully present to the patient, where we are actually here to be with and to serve as best we can.
We mind each other a lot. I mean, so we function as a team. And if somebody felt they were getting too close, we would really be encouraging that they talk to their manager, they talk to me, they talk to one of the senior social workers. So we would have flagged it in their training already.
We do this every day. We'd often think about how it impacts our perspective. I think the biggest thing is, to work in palliative care, you need to begin to really get to know yourself at a deep level, because doing this work will bring up so many things. So lots of what we need to do is think about that as well. And that's where self-development, self-awareness, and the changes in perspective all come together.
You know, we deal with sadness all the time, and families' sadness because they're losing somebody, and the person that we're caring for, their sadness because they're dying and they're leaving their family and they're leaving their life. But within that, even still, we still see the positive things, even within that sad situation. You know, we can still see that there are things to be achieved and to be celebrated. And I think if it was to become a depressing thing where I was feeling sad all the time about what I did, I think that would be time to go then, you know, because then, you know, then you kind of lose focus then, and it just becomes more about you than it does about the people that you're looking after.
when somebody dies, there's always sadness, you know, within us. But there's also, if I feel that, you know, I have helped them even in a little way, there's always that sense of rejoicing, that hopefully it has given them hope for what is about to happen, you know. And also I would hope, one of the things I would always hope for with the people are a sense of inner peace.
I think anyone working in the area would always say that the stresses of it are balanced by the rewards of it, you know, because you just get such satisfaction out of supporting people doing that part of their lives, managing that part of their lives, you know. So I think it's very satisfying.
We had a lady who had played in a band in pubs. I can't remember if she played an instrument, but it was herself and two friends, and they would go to the same pub every weekend and they played music, and she loved it. And she had two daughters and they were quite young, and they were very upset by their mum going, and she had been kind of in an unresponsive state for maybe a few days before, but I had gotten to know her, and I knew how important this music was to her. And I just asked her daughters if they could arrange for her two friends to come in with whom she played every weekend. And we organised for them to we had a big sitting room, and there's a TV and couches in there. So we kind of cleared all that back. And her two friends came in with their instruments and some other musicians. And we brought her bed down to the sitting room, and they played for her, and they played stuff that she would have played with them before. And they had just had the most wonderful night. And then she died that night or early the following morning. And it was just beautiful, because it was just, she kind of went out from the world in the same way that she had been in it, you know.
I can think of one teenager I worked with, and one of my big memories is when she drew out some pictures on the whiteboard about her grief. And she had two people who died, and she was able, excuse me, to talk a bit about, actually she now understood a lot more about what was normal in grief, about coping, about the fact that her grief for each person was different, but yet she loved them both equally. And so there's moments like that where after weeks and weeks of work, you get to a point and you think, okay, they've got it now. I know they'll cope. They'll be sad, they'll be upset, they'll have hard days. But I knew in that moment that she was going to do okay.
I was bringing a patient out. We were going on a trip for the day. This lady was in a wheelchair, and I was wheeling her in Howth, just up the road here. And there was a tree, a beautiful blossom tree. And she said, "Barbara, look at the tree." And I looked at the tree and I said, "Yeah, that's lovely." And she said, "Stop the wheelchair. You glanced at the tree. I want you to look at it." So she made me stop and look at the tree. And I remember when I looked at the tree, I saw that the blossoms had blossoms and they had blossoms on it. And it was really intricate, and I had missed it because I glanced. And she told me that, and I've heard this a number of times from patients, that in her illness, that she looked at everything differently. So when she looked out, and we look and we see trees out there, like she really looked at the trees. She took it all in. She looked at the sky, the colour of the sky, and she felt she was living a fuller life, actually, as a result of her illness. And it just really stayed with me. I tried to take everything in.
I think working in palliative care, you meet people of all different types, and what you do see is how fragile life can be. And it really makes me take each day and appreciate the things that I have, and knowing that I need to make the most of today, because I don't know what the future will bring.
I think you manage it because you know you make a difference. And I think so, it's bigger picture stuff. When you know you've helped someone with pain and symptom control or some psychosocial issues or whatever, helping the family, that's what helps you. You make a difference. And I think that's huge.
Knowing that we have helped people to live, even in the face of a dying that's coming soon, that there is still value in their life and there's still joy and even celebration sometime, and happiness, and reconciliation, and all sorts of things. So all of those things, to know the knowledge that I can be involved even in a small way in that for even one person, let alone all of the people that I've nursed, is just, you can't really describe how important it is.
People talk about hospice dying, but it's not. Hospice is about living when people are dying. And I think that's the difference. It's about making the most of every moment of every day.
I think it's very important to see it as natural. This is what life is. That dying is part of living. So if you have a philosophy that incorporates death, that it's not an insult, it's not a trauma, it's not unusual. You've got to have a philosophy that sees it as very much part of the cycle.
Dying does come to everybody, and it can't be avoided. It's not something to be afraid of. No.
I remember one day a particular lady who had been reared as a Catholic but had given up on God, and going into her actually, a very, very short time before she died. And I just said to her, I said, Patricia, I feel when you open your eyes after death, you'll just go, wow. And she looked straight into my eyes and she said, thank you, Anna. And that was it.
Okay. All right. So does anybody have any questions about hospice or anything to say about hospice? Anybody have anything to say about the video? Everybody's still there. All right, that was obviously in London. And I can tell by the accents, but which was sort of where the whole hospice movement started. And then, like we talked about, moved over here in the early 80s, and has become quite a movement, and in our country as well. So we'll talk more about hospice. It'll come up periodically as we go through the different courses. Your quiz, I thought I had put it in a screen in the PowerPoint, but apparently I didn't. So it is already in Blackboard, but the question is, I refer to this woman as the mother of the modern hospice movement. So just need you to name her. That's your quiz for the day. It's already up in Blackboard. That's a gimme, so you shouldn't have trouble with that one. But if you have any questions, give me a call, and we will talk more later. If you have any questions about anything, the assignment, the cultural assignment, or anything in general, just reach out, and I'll put everything in Blackboard, the recording and the PowerPoint and whatever else, whatever information you need will be there. So y'all have a good weekend. Bye.
You too.
Bye.
Bye.